Assalamu alaikum everyone. My name is Dr. Madiha Abbas and I'm currently working as a senior registrar at Jinnah Hospital, Karachi. So my today's topic is emerging trends in sedation in regional anesthesia. So I will be discussing this topic regarding the equipment, the drugs that we are using, the emerging trends that are going on right now, and what is available and what is not available. So let's start by the introduction. So regional anesthesia, as you all know, is a popular method of anesthesia right now, and recent advances in its technical aspects have provided several benefits over GA. So we are using sedation judiciously in regional anesthesia, and there is proven benefits of patient comfort and analgesia. Next. So the advantages of regional anesthesia, as you all know, is that the patient stays awake and there's early family contact, early food intake. The patient has lesser mortality and morbidity. There's preservation of airway reflexes. There's rapid post-op recovery, stable cardiovascular and respiratory system, shorter hospital stay, and also there's a reduction in the analgesic requirements. So moving on as to why we need to sedate the patient during regional anesthesia, mainly due to fear of recalls or fear of needles or pain. The patient itself is anxious and is fearful. Apart from that, the hospital room environment itself creates fear, the monitor, suction, operating equipments, and so basically regional analgesia and anesthesia actually, sedation actually provides better patient recovery, comfort, and also increases the acceptance of this mode of anesthesia. So moving on, why sedation is necessary apart from the benefits that I have said. It gives a shorter anesthetic method, allows the choice of a shorter method. It can be done in a local regional procedure, and it provides, augments basically analgesia, anxiolysis, and amnesia. It's moving very slow. So what are the risks associated with regional for the sedation? There's respiratory depression, hemodynamic instability, and uncontrolled movements. Cardiovascular instability is usually seen with IV sedation. A trial was done in which is quoted in the British Journal of Anaesthesia. Local block was given to around 17,000 patients undergoing a local cataract operation, in which IV sedatives were used, and predominantly cardiovascular instability was seen in such patients. So hemodynamic instability is more problematic with propofol. Secondly, what is procedural sedation or monitored anesthesia care? It is basically conscious sedation or moderate sedation, in which we used to administer a sedative to a patient in order to reduce the anxiety, discomfort, and pain during medical or diagnostic procedures. Also, the main purpose of our sedation is to augment or reduce any pain which regarding if any block fails or there's a partial block. What are the applications of procedural sedation? We use this in invasive diagnostic tests, in minor surgeries, in emergency medicine, outside the OR. Now regional procedures are very common. And again, our goal is to balance the level of sedation to provide comfort without compromising patient safety. An ideal sedative should have a rapid onset of action, should be easy titrable, should have a short context-sensitive half-time, should be rapidly eliminating from the body, minimal cardiorespiratory depression and other side effects, lack of tolerance and withdrawal symptoms should be minimum, and inexpensive, cheap effect, it should be cost effective. So the commonly used sedative agents right now in our ORs are benzodiazepines, propofol, ketamine, clonidine, dexmedetomidine, and opioids, in which we have fentanyl and remifentanil. Before going towards these agents, we can talk about a little about pre-medication, which is now an emerging trend. And midazolam has excellent anxiolytic and amnetic properties, and it decreases propofol requirement, does not prolong recovery stay. Apart from that, clonidine is also a drug which is better regarding pre-medication. However, it does not produce amnesia at low dosages. So in benzodiazepine, we have midazolam, which is preferred for sedation due to rapid onset and offset. Apart from that, midazolam, the main drawback is dosage-dependent respiratory depression and decrease in arterial pressure. It has no specific analgesic properties. However, it has a safety factor of providing a specific antagonist, that is flumazenil. Propofol has excellent sedative properties because of its pharmacokinetic actions. It has a faster onset and offset, and leads to less post-op impairment and recalls, and has a greater patient satisfaction as it is cleared from the body very rapidly. Then we have, it can be delivered through the transfusion TCI pumps, targeted control infusion pumps, and patient-controlled sedation are emerging trends right now. So for initial loading doses and bolus doses, we have 0.2 to 0.5 mg per kg, and which is then further maintained at 0.5 to 4 mg per kg per hour. However, the TCI method now, we actually target blood concentrations, which is 0.4 to 1 mics per ml, and depends on the age of the patient, and if any drugs are used for pre-medication. So remifentanil is a popular drug for sedation, and propofol and remifentanil are used in TIVA. The metabolism by esterase and half-time is very short, about 3.5 minutes, and recommended dosages are 0.02 to 0.25 mics per kg per minute. So apart from that, it provides excellent patient comfort, and there is a greater hemodynamic stability with propofol and remifentanil together. Next. So then we have ketamine, and again a very excellent drug for procedural sedation and analgesia, minimal cardiorespiratory depression, and profound analgesic effect. And however, it has adverse psychiatric effects, which can be prevented if it is used as a monotherapy. However, it can be prevented by giving initial sedatives such as midazolam. And mixture of ketamine and propofol, which is called ketofol, is an excellent drug for sedation without any cardiorespiratory depression. And hence, by using ketamine, we can actually decrease the need for opioids. Then we have the drug dexmedetomidine. So this is a trending drug right now used for sedation and also for pre-medication in pediatric population if used 30 minutes before a procedure by intranasal route. However, there are residual sedative effects the drug is still under trial, and it has a relatively long half-life of around 2 hours. The effects are basically dose-related, which are hypertension and bradycardia. That is why it is still under trial right now. And however, at low doses, it creates a better sedation effect. So an emerging trend right now is the use of CEVO in European countries. CEVO was used for burns dressing and now as an analgesia supplementing regional, that is epidural, in these countries. And for procedural sedation, it is off-label right now and only licensed for induction and maintenance of GA. Low-dose CEVO has been used to provide brief periods of analgesia or sedation and is probably safe. Nitrous oxide, as you all know, Entonox, is preferred for procedural sedation and excellent for labor analgesia, and however, it is underused in other applications. When compared with midazolam and fentanyl or propofol or fentanyl, Entonox was found had efficacy equally to that of both these combination of drugs and gave lower pain scores. However, it is a greenhouse gas, and environmental concerns are basically the issue right now. Then the recent advances in sedation are basically olisridine and remimazolam, which have rapid onset and metabolism and predictable recovery times. Apart from that, multimodal sedation techniques are in trend now, and combining these agents to balance the sedation depth with analgesia are actually under trial. So remimazolam is a water-soluble benzodiazepine and has a rapid onset of action. Its metabolites have negligible side effects because it is hydrolyzed by esterases, as you know, same as remifentanil. Patients recover rapidly and with psychometric measures returning to baseline sooner as compared to that of midazolam. And it is constituted from a powder and must be used immediately. And it is licensed for procedural sedation in UK, Europe, and USA. However, it is licensed for induction and maintenance of anesthesia in China, Japan, and Korea. Also, olisridine is a new opioid analgesic that acts as an agonist at the mu-opioid receptors. When used IV for acute pain, olisridine is shown to be non-inferior to morphine. And olisridine also has fewer adverse effects as compared to that of morphine. And combinations of olisridine and remimazolam and olisridine and propofol have been proposed for gastrointestinal surgeries, endoscopies, and regional also. So methoxyfluorine inhaler is another addition serving as an emerging trend, and it is a single device inhaler. Up to 3 ml can be inhaled and provides excellent sedation, and it supports basically 25 to 35 minutes of the procedure. And however, due to fluoride ions, we have to be careful. Not more than 6 ml can be inhaled at a time. So mostly done for dental extractions, and now it is officially licensed in Europe for analgesia. So techniques of sedation are normally what we used to do were single or repeated bolus techniques and continuous infusion with initial bolus. Right now, the emerging trend is using of TCI pumps, patient-controlled sedation, and the under trial right now is patient-maintained sedation. So single or bolus repeated techniques lead to unstable blood and effect site concentration profile, and adverse effects can be seen due to peak concentrations and variability of sedation levels. Continuous infusion, on the other hand, leads to variable sedation levels, and it has to be, there is no basically repeated administration of infusion rates to maintain a defined sedation level. So with this problem can be overcome by TCI. TCI, on the other hand, consists of microprocessor controlled algorithms, preset, and there is stabilization of the concentration and tapering of the concentration. So it is much trending right now. Target controlled infusions, in this the infusion to the patient is given based on achieving calculated blood concentrations as a target. When the target is achieved, the pump either stops or slows down. Newer algorithms in TCI are based on effect site concentration now, and this results in a faster onset and better control of the drug effects. So the effect site concentration is right now is targeted to 0.4 to 0.8 mics per ml and 0.5 to 1 nanogram per ml for remifentanil in most of the cases. Patient-controlled sedation, on the other hand, is preferred now due to higher patient satisfaction and lower sedative consumption. The patient basically controls the delivery of the sedative agent by using a button which is linked to the pump, just like patient-controlled analgesia pumps. Basically, these pumps are modified and then repurposed to form patient-controlled sedation pumps. There is a lockout feature which prevents the excessive drug delivery, and there's higher patient satisfaction. A patient can increase the target concentration as per their needs. Patient-maintained sedation is still under trial, but in most of the literature now supports that in this method the patient has to increase the target concentration in basically target-controlled infusion method. There's target-controlled infusion pumps which are linked to a trigger button, and the patient basically presses that button and the drug is released. However, this is only preferred for light sedation. So the equipment needed for sedation: infusion pumps, basic airway, advanced airway management, emergency resuscitation equipment, and a pharmacological antagonist if it is available. Infusion pumps are basically the means of giving propofol and remifentanil. How do we assess sedation? As an under sedation can lead to increased chances of awareness with recall. Over sedation can result in cardiovascular instability. Preferred methods and common methods include machine-based, patient-based, and observer-based methods. Nowadays, an emerging trend is observer-based methods, which offer a best alternative for assessing sedation. Monitoring of sedation basically includes monitoring of vital signs and ECG monitoring, assessing the depth of sedation by monitors, and recently capnograph has been considered mandatory, and recent trends are EEG-based monitors. So capnography is basically can be done simply by inserting a sampling tube inside a standard face mask, and it is now considered mandatory while giving sedation. EEG-based monitors include WIS monitors, which are commonly used now. Apart from that, narcotrend and auditory evoked potential monitors are emerging techniques, monitors now, due to lower hemodynamic changes, and there are fewer complications. So for essential monitoring, current guidelines require hemodynamic monitoring, arterial BP, ECG, oxygen saturation. Propofol sedation is particularly problematic, so it requires vigorous and extensive monitoring. Capnography, as I said, is mandatory. So by assessing the depth of sedation by scales such as Ramsay sedation scale, as you all know, modified Wilson scale and observer assessment of alertness sedation scale are emerging trends. Visual analog scale is basically done by the patient itself and only applicable for light sedation. So what are the factors influencing the level of sedation? That is the spinal and epidural the regional anesthesia basically itself, and it is dose related, and it has a positive correlation between the depth and the extent of the block. And peak sedation effect basically is seen after 30 to 45 minutes of the block, and mainly due to the inhibition of the reticulothalamocortical tracts. Apart from that, the addition of certain adjuncts also enhance sedation, that is such as adrenaline. It provides hypnosis and lights and amnesia also. And it also has peak effects within 10 to 20 minutes. So non-pharmacological methods are also trending, which include listening to music, which according to the recent literature has reduced sedative consumption and decreased pain scores and higher patient satisfaction. So the use of sedation is growing exponentially, and there is increased need due to higher rise of regional anesthesia. There is increased patient acceptance, and growing sedation techniques are increasingly being used outside the OR. And there are better understanding of the sedation drugs and enhances patient safety. So sedation basically significantly improves well-being during surgery. What are our challenges and future directions? So there are basically the cost implications regarding the newer sedation drugs and the technologies that are introduced. And apart from that, training is required for the nursing staff, the paramedics who basically provide these services, and the anesthetists themselves. Thank you.